Welcome to our latest episode of the Lebanese Physicians Podcast. And today it's an episode with Dr. Zakia Dimassi. We go back a long time, and actually I had done an episode with her the days of the revolution in Lebanon, and when she was a doctor for the revolution at the time down in downtown Beirut, and now she is in Abu Dhabi. But she is in medical education, and she has recently published an article in clinical simulation and nursing discussing fatigue in standardized patients, and that is why we invited her to the podcast. Welcome, Dr. Dimassi, to the podcast.
Thank you so much for having me, and it's good to see you again. It's been quite a while, and I'm really happy to be on today to discuss this publication together, inshallah.
Yeah, thank you. Hopefully people will learn a lot from it. So, Zakia, can you just give us a background of how you got involved in medical education and what you do at Khalifa Medical Center in Abu Dhabi in medical education?
So I'm a trained pediatrician. So I did my medical school and residency, but upon finishing my residency, I wanted to do like 1 year of research before moving back to my hometown in Lebanon and starting my private practice. It was either pediatric hem-onc or medical education. And albeit I wanted pediatric hem-onc as a fellowship, but for some reason, one of my friends who was in med-ed before me, med-ed as in medical education, she spoke to me about it, and something attracted me about the concept of, the science behind creating medical curricula and a medical and then learning experience for students. And I felt this is where you can intervene to improve the learning experience. And perhaps mine, albeit it wasn't bad, but I felt there were some elements that I've always yearned for and they were not there. So I thought I would take it for 1 year, and obviously it's going to be literally a little bit chill, right? So I thought, I can relax after 3 years of residency. There's no harm in that. And during that year, it was in the American University of Beirut Faculty of Medicine. They were overhauling the curriculum. They were moving from didactics, so a lot of lecturing, teacher-based, to outcome-based, or what we know now as competency-based and student-focused, right? And the fact that I'm a trained clinician, I was working primarily in clinical skills and simulation. And I was learning as I was learning as I was working. So it wasn't something that I had expertise in. And I just fell in love with it. I found an untapped passion. And, I was fortunate enough back in the days that the leadership at AUB were kind enough to sponsor me for a master's in health professions education. And I just took it as a career, and I've been doing this for the past 14 years.
Yeah, I know you did it in AUB, then you did it at St. George afterwards, and then you moved to Abu Dhabi, and you've been doing it since you moved to Abu Dhabi 5-6 years ago. So what inspired you? Because we all do simulation sessions. We have medical students or trainees deal with standardized patients, but what inspired you to study fatigue? And because we never think about it, I think oh yeah, they're doing it, that's fine. But what inspired you to study fatigue in these standardized patients?
First off, I've been working with standardized or simulated patients or human simulators. There are different terms for that nowadays. Ever since I began working in clinical skills, they're a cornerstone and a pillar in any simulation-based activity. And they are, in terms of fidelity and realism, so the closer to reality as possible, they are the highest, obviously, because they're human beings. And working with them, it was not only for me just to make them familiar with symptoms and how to respond to students and how to do assessment, but also I learned from them, because when they come to you with questions, they shed the light on things that you assume are clear, but they're not, especially for the non-medical people. So I became very fond of the concept of working with standardized patients. And back in AUB, before I left, we were in the process of we put the fundamentals of the SP program. We had a website to recruit people. We worked with people from the theater to train them properly on the portrayal of symptoms and such. So it is quite a multidisciplinary input into this kind of field, and it just brings a different perspective, which is closer to the patient, even more so than from the medical expert. Now, in terms of fatigue, obviously, when you do something for a long time, you observe things. It doesn't have to be because you read somewhere about it, but you observe things. And I have always wondered, starting from reflections upon myself, if I have to repeat the same thing over and over and over again, the exact same thing without moving the needle just a little bit, I would be bored out of my wits. That's number one. Number two, I always wondered as well, like certain physical examination maneuvers, like, the pupillary light reflex, the other reflexes, like examining, like putting like a tongue blade, or constantly having the blood pressure cuff inflated, then deflated, and that would cause some, numbing sensation and at some point. So that these will induce, they will probably make the job hard, and you will feel probably fatigued or tired. And finally, when portraying very challenging cases like receiving bad news, or portraying the role of a patient with, for example, a daughter or a son bringing their parent who has dementia or Alzheimer's, and that kind of emotional strain that comes with the case, that takes a lot of energy. And funny enough, we were just going around the simulation center at Khalifa University, and we were just having a discussion, and I'm like, we don't study standardized patients enough. And I'm fascinated by the concept of fatigue. What makes them fatigued? What is the frequency of activities before they feel like they have capped? Even for us, when we did our residency training, you cap at a certain number of patients, and there's a science behind that. It's not random, right? There are concepts of safety related to that. So this is how the idea came around, and just so we pursued it, we then started doing proper literature review to see what's already out there and what is really missing in the literature. And we realized that the perception of the standardized patients, especially because they become experts themselves, has not been looked into properly.
Right. So why do you think it's an important issue, and why do you think it's been overlooked in simulation-based education over time?
Yeah. Now, I don't know why it hasn't been really overlooked, but it hasn't been explored in depth enough. It is important primarily because standardized patients, again, as I mentioned earlier, they are a pillar of any simulation-based activity. So their contribution is essential. A scenario where you include a standardized patient comes to life with how they portray the condition, right? And they have to do that consistently, providing similar responses or exact same responses across multiple students, so that you're speaking about validity and reliability. So that's this is what you want in any assessment, right? They are also, in certain organizations, they are tasked with scoring. So that is core educational role, right? They are scoring maybe formative, maybe summative assessment. So their ability to perceive the output by the learner as it should be perceived, objectiving it, and doing so within, usually it's like short period of time, because they're like, it's a one student after the other. So they have a limited amount of time to really sort of retrieve whatever were able to capture during the encounter, and scoring properly without missing information or without getting mixed up. That is very important. So their role is so important that you really need to understand what is conducive to it becoming enhanced. How do you improve on their ability to function? And what are hurdles or obstacles that exist, maybe because of the design, maybe because of the inadequate training, maybe because of malalignment between the perception of a standardized patient, especially those who come from a non-clinical background, and those who design the exams, who are usually in the clinical field. So you would really want to understand how to optimize their function, and accounting for all these factors that come into play.
Right, because also for people who don't know, like their roles are anywhere from like procedural based to history and physical based to OSCEs to other assessments, and sometimes they have to go from room to room discussing the same scenario over and over again with different groups of medical students, let's say. So it could take several hours when they're doing their job at that point in time.
Absolutely. So usually it depends on the volume of the operation that you're running. It could be something very simple, like maybe like a few simulation scenarios and a formative setting, or a lot more, stressful, which is a more summative setting. At some point before the Step 2 CS was retired, SPs were utilized in Step 2 CS, and we know how, this is a very high stakes assessment. So their role is also, it's the ability to keep their performance exactly as it's supposed to be. And that's why we call it standardized, because there is no room for variability. You cannot have variability across scenarios or across learners.
Right, right. And so how did you study fatigue in your study? Like what tools did you use to study fatigue in these patients?
Mm. So there was no existing tool. So what we had to do was develop a de novo survey. And to do that, we had to do extensive literature review to see what's already out there. And the Association for Standardized Patients, the ASPE, they have a lot of references related to everything about how to regulate SP programs and training SPs, the ethics of working with them, their rights and responsibilities, so on and so forth. And there was a few studies all the way, dating back to the early 90s, all the way to the 2017, that looked into elements that may contribute to burdening the standardized patients or making their job a lot harder. But these were based on experts' opinion, right? They were not taken from direct interviews or discussions or questionnaires given to the SPs themselves. So we based our survey, our de novo survey, on the findings of the literature, not to mention because the team that did the research, we're experts in simulation. We've been doing this for quite some time, and we work with standardized patients. So our expert knowledge was also brought in. And obviously we had to run the stats to ensure that there is construct validity, content validity, and so on and so forth. And we ended up with, oh, sorry, go ahead.
No, go ahead.
We ended up with a survey that was a bit long, but luckily the participants took it very seriously and they filled it to their best. It was around 65 questions, and some of them were open-ended questions. So all in all, it was a mixed method study. So we had the quantitative component, which is multiple choice questions, and then open-ended questions where they would, expand on multiple choice questions. They would just write like written narrative comments.
Yeah, exactly. Expand on the findings that they found. But one thing that surprised me actually in the study was that fatigue sets in very early. Like some of them were fatigued within around 30 minutes, and some of them took like 5 to 6 encounters and they were fatigued by then. Did that surprise you?
To a certain extent, not really. So when we looked into literature about fatigue, we combined it from the perspective of simulation, so the realm of simulation, so what has been already reported. And it has already been reported that this is the kind of average that is, so within 5 to 6 learners or 30 plus minutes, this is when SPs usually feel fatigued. But then we wanted to look at it from the concept of fatigue itself, which is still probably it was never approached that way. So we looked at the different components, so to speak, or factors of fatigue. So you would have the physical fatigue, like the examples we have given about the blood pressure cuff being inflated, then deflated multiple times, the pupillary light reflex and the knee jerk reflex or something. So these are physically very annoying to do and to be done onto you. There is the cognitive fatigue, which is because you're having, for example, if you have a very long checklist and you have to memorize all the items and make sure you mark them correctly. If there are complicated medical terms or I don't know, diagnoses or even symptoms that may be a bit complicated in a complicated case. And then there's the emotional fatigue, which comes primarily from the portrayal of psychiatric conditions or anxiety, breaking bad news, receiving the bad news, or receiving bad news about a diagnosis, for example. So we wanted to see the interplay of these different facets of fatigue and which one exerts the most effect on the standardized patient. And this is how we looked at it. But again, in terms of the number, the threshold that you mentioned, it wasn't that surprising because it has been already published before. And the study was, I forgot the name of it starts with a P et al. In 2017. That was like a seminal article
On that. And yeah, because 30 minutes is very early. Like it's probably at the start of the session. It's not like they've done 2 hours session at that point in time. And it looks like you found that emotional fatigue actually exceeds and is more than cognitive and physical fatigue. Why do you think that is the case in these patients?
Yeah, so the fact that emotional fatigue sort of supersedes the other two, and it's sort of like they can get over physical fatigue and cognitive fatigue, but emotional fatigue overshadows. And I think the fact that the acting component, it just takes so much effort to portray that kind of role. It's not really, you need specialized training. And this is what we realized when we looked at the comments. And that's why we specifically chose the title, It's Not for Everyone. Really, specifically for those roles, one of my favorite quotes, and I'm obviously not saying it verbatim, is one SP was saying that they had to play the role of a patient who were planning to go on vacation, and then they received a diagnosis of cancer of some sort. They said, I couldn't get over it, and I'm never going to take such a role again. So having to engage with learners, and obviously because you take the emotional burden of the learner who is breaking the bad news and seeing your reaction. So it's a lot of emotional exchange happening. And funnily enough, yes, that did reflect on cognitive load or cognitive fatigue and physical fatigue. And from a human experience perspective, if you think about it, there's a lot of psychosomatic disorders. So even the psyche can manifest as something physical. And people who are overwhelmed emotionally may not be able to be as productive as they are baseline. So I think it aligns nicely with what we know about the interaction between psyche and somatization and such.
Yeah. Yeah, because there's a lot of cases, what people don't know, there's a lot of cases that are like very emotional, such as like psychiatric cases or somebody passed away or something like that. So it becomes like they have to repeat these cases, and that probably is part of the reason also that this happens.
Absolutely. And even you so once this was before we did the study anyway. So we were developing a scenario whereby a woman brought in her mom who was starting to develop symptoms of dementia or potentially early onset Alzheimer's, versus that she was mourning the loss of her husband. And it was a very emotionally loaded scenario. And we were just videotaping it. I was playing the role of the student because we were doing the benchmarking and standard setting of what is a good performance like. And that standardized patient was very good. I ended up tearing up. So she was crying. I almost choked on my own tears because it was such an emotional scenario. So you can imagine if this has to happen 5, 6, 7 times in a row. So there's a lot of emotional exchange. I'm just basing it off of a single experience, and I'm sure many people will be able to relate.
Right, exactly. And how does it manifest, I guess, during an OSCE session? Because OSCE session could be about 3 hours, right? And so
Mm.
how does fatigue manifest? Like, how do you notice it? Do you notice it in these patients or?
We notice if obviously they try to maintain high levels of professionalism, and I think if you also look into the qualitative part, many of them say, "Well, I'm doing my best to keep my performance up to the mark," but they do admit that they start confusing learners, or their responses become more automatic, right? Like very robotic, because they're not able to give it 100% anymore, and they may not be as accurate in their scoring. And this was an alarm sign, obviously. If you are engaging or involving your standardized patients in the assessment and the actual scoring, and they are telling you that my scoring is inaccurate because I'm fatigued, this is where you need to reconsider the workload that you are assigning per standardized patient. So usually you would probably notice that they are making mistakes, or in hindsight, you would get students coming to you, well, yeah, that standardized patient, well, I want they contest their grade, they're looking at their performance, and they say, well, the standardized patient didn't tell me this. And then you would realize, but this was part of the training and part of the scenario. So you go back and you watch and you observe and you see lapses in performance, and could be due to fatigue. So you can observe these either directly or because of reports by the student. There were like lapses in performance. And obviously in the study, they have described it very eloquently. Like they said how they get confused or get mixed up, they get foggy and such and such.
Right, because I've seen it actually myself. I've done OSCE sessions before, and sometimes they give you the scenario beforehand so you could be observing it and you feel that that standardized patient is not answering the same questions or not giving the history that was supposed to be given to the students.
Yeah, and I think there are a lot of ways to mitigate. The standardized patients they made suggestions on how to do that as part of the study because we wanted them to make suggestions. And so you could have like a floater SP or a backup SP, like we used to have the float team, I remember. So they would relieve you at a certain point. You would have more rigorous training. The benchmarking, the standard setting, you would have them watch a video all together and have a discussion on because this is the standard performance. So how do they understand it? How do they make sense of it? Giving them that room to walk around, take a break. So proper insertion of a break time, so it's not too intense, and enough break time to unwind, to stretch a little bit, some refreshments, just because they need to eat. And I remember, those elements that can be easily incorporated into how you design a typical OSCE day or a simulation day. So you have to be more mindful about the workload and its effects on them, and accordingly you would do better scheduling, and even the educational space would be slightly modified so as to allow for the stretching, stepping outside of the room, so that they're not stuck in that OSCE cubicle all the time for the duration of the assessment.
Right, that is important, because any one of us, if you're stuck in a place like for 3 hours, you're going to be fatigued even if you're doing nothing in that
Absolutely.
case.
Yeah.
And one of the things is that 70% of SPs felt fatigue affected their assessment accuracy. That's quite a bit, actually. That's a big number, right?
Yeah. Obviously, we did not have the ability to assess whether this number that they have or their perception of lack of accuracy actually happened, because obviously we were not looking at which OSCEs they have scored. We had a cohort of 123 or 124 SPs internationally, so we could not validate whether this assumption is correct or no. It is their personal assessment that they were making mistakes while assessing. So, but the number is significant, and it tells you, again, it reinforces the fact that first, this is not some random or individual perception or, a personal experience. It cuts across different SPs from different parts of the world. It amounts to a significant percentage, and it means that something is not being done right in the workflow design. So things need to be reconsidered, and starting from when do they receive the scenarios, how often do they train, do they receive feedback, is their performance assessed? Like I can tell you at Khalifa University, when I joined, we were not assessing the SP's performance themselves. And then I decided that I wanted to include that. It's important because they need to get the feedback. Did I do well? Not only from the students' perspective, because students are under a lot of stress, or the examinees. So they may not be, the best or not sufficiently the good assessors. You would want different perspectives. So you want the clinician or the SP trainer to be also going around or watching the videos and looking at the performance of the SPs and scoring them and giving them feedback to improve their performance. And a lot of the SPs who participated in the study take it very seriously, and they say, well, I do it because I want to train the health professionals of the future. I think I'm making a difference. I'm learning more about healthcare and communication with healthcare professionals, and I want to do better, and I want to receive feedback on my performance.
Right, exactly. And I think feedback is always important, because also probably it'll help them correct whatever they may be not doing right, or what they think they're doing right, but then it opens up their eyes to that. And because also we always assess the performance of the trainees or the students, so why not assess the performance of the SPs? So do you think we're introducing like bias or variability into high stakes exams because of fatigue? And are we impacting pass and fail decisions, I guess?
Hala, to a certain extent we may be, and obviously these findings should trigger reassessment or re-examination of how we design and develop these exams, and how much weight we give them. Now, obviously, competency-based medical education brought into the picture programmatic assessment. So there are different components that come together to create the portfolio of the students. So it's not one assessment that makes or breaks students' performance. Nevertheless, we need to reimagine how we conduct and we conduct OSCEs. We need to be more mindful about the workload and what is required from the SP. And you have to break down the task. And this is something that we put in our conclusion. We need to have a more breakdown of a typical task given for an SP and understanding really from their perspective how much load it takes, or the workload from their perspective. How many hours does it take to actually perfect the scenario? Are they up to engaging with psychiatric roles or not, right? That's something that you need to also get out of the way. And offering them more support in terms of, as mentioned before, breaks, proper training, feedback, the environment, the setup, and also something that may be also slightly overlooked, which is de-rolling. So de-rolling is a practice also that is borrowed from theater. So just helping the actor or the standardized patient in this case detach from the role they have been playing for hours on end. So all of these practices are important if we are very serious about, if we're serious about assessment. I'm sure all of us are. And what I would say, but eventually, there is no bias-free assessment. We're humans, we are naturally biased. So if we want to probably minimize bias, you could have additional source of assessment by utilizing technology. And nowadays we all speak about AI-powered assessment, for example. And in this case, your audiovisual recordings can be also analyzed by AI, and you can see the extent of alignment between the SP assessment and what AI tells you. And this way you can probably reduce the bias to some extent, I guess.
That way you might have a better objective assessment.
Absolutely.
Subjective assessment in that case. And so can you compare, I'm thinking about it now, because as physicians, you're always seeing patients sitting in a clinic room all day long. Now, sometimes now in the US, you see 15-minute appointments and you're at the end of the day and you get fatigued. Do you think SP fatigue can compare to physician fatigue or cognitive overload in clinical care?
To some extent, it might. Obviously, the stakes are lower because you're not harming patients. You're not doing any care. So and simulation is by definition a safe environment to make mistakes and learn from mistakes. So yeah, the stakes are a lot lower. Nonetheless, because the effect is cumulative and because the grooming of medical students or healthcare professionals or healthcare profession students, before they become professionals, it's a lengthy process. And it is that construction that needs to be done on sane and healthy grounds. I think, yes, we need to take it seriously. It shouldn't scare us off, obviously. It shouldn't deter us from utilizing this assessment modality. Nonetheless, again, the potential for improvement is there, and there are avenues to improve on things. And because it is still utilized worldwide, I think it's important that we look at it again and take it seriously enough to make changes. And we all know that change is painful and people are comfortable with producing things in a certain way. But I think with these numbers, it's high time that, OSCE design should be a bit revised just to accommodate more for those SPs. And as well, the fact that since they have expressed the seriousness of the effects of fatigue, the fact that you want to make change, it's an acknowledgement to the importance of their role, and that the fact that if they feel they're not delivering properly, that you want to make changes to help them perform better.
Right, exactly. And I think a lot of them would be open to that.
Yeah, absolutely.
So what are some predictors of fatigue, I guess? Or was it equally among everyone, or were there some predictors of fatigue that you found?
Yeah. Funny enough, we found that people from non-medical background, people from Asian ethnicities, were more prone to fatigue, and also people from the Asian parts of the world and females were more affected by emotional fatigue. So these elements were, again, this is a limited cohort. It's only 124. There are not that many. So probably expanding on this and looking more into a larger cohort would be more telling, and doing more in-depth interviews to understand better what factors contribute to that. I remember from medical school that we learned, the pain scale, that it's very subjective. And I remember that we learned that people from certain ethnicities have a lower threshold of perceiving pain, and you cannot tell them this is not painful. So what I perceive as 7/10 for you may be a 3/10, just an example.
Right.
So that could be something that could be looked into from that perspective as well. So yeah, I mean, these are the predictions that we found, but I mean, I would like to do a deeper dive on this.
Yeah, so yeah, these are some of the predictors we found, but these are not like 100% at this point until like more studies, I guess, are done to confirm that.
Absolutely.
But one interesting thing I found was that if the SP is experienced, more than 10 years of experience, looks like they're more protected from fatigue. Do you know why that is?
We didn't have anything in the open-ended questions that would shed light exactly as to why. But my presumption is that because they become more habituated, I guess. And, I don't know if it's also related to quote unquote erosion of empathy to a certain extent, because there's quite a bit of empathy between the rapport of the standardized patient and the student. Usually, from also, again, these are not based on empirical data. From my discussions over the years with standardized patients, they tend to be more forgiving of younger medical students. And as they are assessing more advanced learners, they become more strict with them because they have higher expectations. And also SPs with more experience become harsher assessors, I guess. So I think they become their depth of experience, their perceptions become more refined, and their expectations are higher, and they are so focused on getting the work done probably, so it's not that difficult for them to engage on the job. So I think it's just a matter of a learning curve. Maybe you become better at what you do, and you cancel out what could impede your performance. I'm not sure. So again, a deeper dive is really due in this case, like trying to understand, like comparing or having a focus group discussion that has people with 2 years of experience versus 10 years, and asking those interesting questions and seeing what do they have to say.
Right, as you were saying it, I would compare it like because I'm like a pulmonary intensive care physician. Like intensive care physicians, when you start at first in the ICU in your first year, you always like feel like very emotionally affected by any situation that happens. I mean, of course, your empathy is still there, but with time, you're able to detach yourself from that and be able to continue with your day without being as emotionally affected by the situations that are happening around you. And probably it's the same thing, I guess. So based on your findings, what are the top 3 changes every simulation center should start and do tomorrow?
I would say when configuring your schedule for an OSCE activity, make sure you include reasonable number of breaks in between sessions, so as to prevent, so that is aligned with that identified threshold of fatigue. So maybe by 30 minutes, have a 10-minute break, and not make it too long, because too long would also be too disruptive. That's number one. Number two, make sure that there is a space for people to stretch, to walk around, to grab a snack, and to like discuss with one another. So step out of the room and come back. And number three, I would say also is proper de-rolling. Just do de-rolling. Help them step out of that role that they have taken on, especially when it is emotionally draining. The technique of de-rolling needs to be learned. I don't think all standardized patient trainers know how to do de-rolling. So that there is an element of continuing professional development on that front, that people need to acquire the skills of de-rolling so that they can help the SPs de-roll, especially for emotionally loaded roles.
So when you say de-roll, it means like the SP is doing this role, for example, today in the OSCE, but maybe next week they might not be doing. They may do a different
No,
role, or is it
de-rolling
the same,
is help.
same day?
No. De-rolling is basically at the end of the activity. It is a technique that is employed in the theater to help the actor or the standardized patient get out of the role emotionally, right? Because when they rehearse it so much, and there's so much, it becomes a lived experience during that period of delivery of the role. And then sometimes they go out from the simulation or from the OSCE still carrying the story. It haunts them in a sense. So you help them and just getting out of the role, right? That's pretty much de-rolling. Now, whether they're gonna play it again or no, I don't know. I didn't come across of anything that says whether you should or shouldn't. Obviously, unless the SP declines it because they found it too heavy, quote unquote.
For them, right.
Mm.
And interesting. That's an interesting fact. And before we end, I was going to say there's no podcast these days that we would not discuss AI integration into it. Do you see
Yeah.
a role for AI or hybrid simulation models to reduce SP fatigue?
Yes, I think the power of AI can offload a lot of, especially cognitively, right? Because AI cannot, until in the current existence of AI, it will not replace the SPs specifically for physical examination, or it can probably give history probably, but I don't know how well it can trigger that emotional response. And you can have virtual SPs now, right? I don't know whether they will be able to replace real SPs, but obviously for you to build the SP avatars, you need to train the machine using real SPs, right? So real SPs will have probably the role of training the AI to utilize virtual SPs, which becomes a tool to help with SP fatigue. So you would have that hybrid role in certain areas, maybe help with the assessment, and for equitable access. So for people who can't afford to hire SPs all the time or at all, or have an SP program, maybe a software would solve the problem. Not sure the software would be cheaper, but just this is what would be ideally there. And obviously the ability of AI now, because we speak of multimodal AI, so it can read not only text, but it can also learn from the audiovisual recordings and analyze the audiovisual recordings by transcribing them and looking into what was said, how it was said. So, and looking into different indicators of performance and supporting the input of the SPs at this stage, at least. So these are potential areas for incorporation of AI into simulation-based activities that would help offload and better standardize as well.
You see it might take away from human realism?
I do. And this is just an inkling and my instinct, but that's just me. I mean, I'm learning about AI and I'm trying to apply it every day. But I don't know how that holistic experience of physical presence and a human-to-human interaction, whether it can be replaced by AI. My premonition is that no, it cannot.
Yeah, we'll see. Yeah, but it looks like from what we know right now is that AI probably will not be replacing SPs anytime soon, but it probably will be augmenting the role of SPs.
Hopefully it will be utilized in that fashion. Otherwise, I think it's going to be a very isolating experience. Not to mention, I also have reservations about the ability of us humans to transfer the learning from strictly AI, strictly virtual to real patients, because at the end of the day, you're going to give care to real patients. So
Right.
how is the transfer of learning going to be like? Long-term outcomes, not only short-term. Not I'm training today and I apply it next week and wow, I'm doing great. How is it going to be down the line, long-term?
Right. I'm thinking about it could be helpful, like for example, simulation, like flying for pilots. It helps them get to fly, but you're not gonna do have the pilot do a simulation session and then take a plane full of passengers across the world or
Yeah,
something
I
like
mean,
that.
even let's say you do augmented reality for CPR, but then when you're going to compress a real chest. You're not going to compress a virtual chest. So, I don't know.
Right, exactly. And if you had to summarize in one message for educators, what are we getting wrong about SPs today? Just in summary.
We don't involve them enough so we need to co-design with them.
With
We
them.
need to co-design simulation-based activities with them. Yes, they are as much part of it as we are.
Exactly. Because that could lead to fatigue, you're right. And what would an SP-centered OSCE look like?
Again, it's an OSCE that is co-designed by the SP from their perspective and how they want to be treated as patients. and what the role should look like, and the terms that are used, and the realistic load of a checklist that they're supposed to correct, and elements that would make their experience more enjoyable in a sense, and not overloading to the extent that it affects them negatively and deters their performance. So that would be an SP centered, and again, them receiving feedback on performance from the students, from the faculty, from the simulation experts or standardized patient trainers, so that they again feel at the center of the activity and that their role is of value and of impact as well.
Excellent. And the last question is, what is the next research question you want to answer?
Probably, well, we may be looking into validating this survey, because it's not, I mean, so we want to go into the psychometrics of it. That's one thing. And we would probably want to see the fatigue as perceived by clinician assessors. So when you do the assessment, not the SP, right? So when the SP is there just to do a role portrayal, when do you start questioning whether you're scoring correctly, or you're just, I'm too tired, I can't focus anymore?
Right.
Maybe that's something I would like to look into as well.
Looking forward to the results of that. Hia, thank you very much for being on the podcast, and it's great to connect with you again.
Thank you so much for having me, and I look forward to watching this episode and many more episodes, inshallah. Thank you so much. That would help offload and better standardize as well.
You see it might take away from human realism?
I do, and that this is just an